Hi, good morning. This is Dr. Jacqueline Holt. I'm the medical director at Delaware Imaging Network and Women's Imaging. And I know that you have already heard from Dr. O'Hara today about the high-risk patient, and I'm going to go over now some screening techniques that we use daily for breast imaging. I did diagnostic radiology residency. I'm a Delaware girl. I've been in the area for 25 years and did a fellowship in MRI. I have no disclosures at this time. Now, the topics today that I would like to discuss with you are what screening in general for the breast, what is the goal in screening, the current screening modalities that we have for breast imaging. I want to talk to you about 3D mammography, also known as digital breast tomosynthesis, also breast MRI, and an abbreviated version of breast MRI, either called FAST or abbreviated MRI. And I will mention briefly about the study that was done in the United States, that Delaware, that we also took part in, and it was a major study, the ECOG-Akron trial for FAST abbreviated MRI, which led to the article in JAMA, the Journal of the AMA, on how to screen with breast MRI, fast breast MRI. So really the goal of screening, what do we really want to accomplish with that? And we're trying to, of course, decrease breast cancer mortality. Dr. O'Hara already talked to you about the rate in mortality and high risk, and also decreasing breast mortality. In addition to that, it's the reduction in what we would say the morbidities associated with surgery and chemotherapy. So if you can find cancer at an earlier stage, you can reduce the amount of surgery needed instead of mastectomy, lumpectomy, and also in some cases alleviate the need for chemotherapy if you can find breast cancer at its earliest stages. Now, the randomized controlled trials, which were done in the 1970s, and you may have been hearing in the news, randomized controlled trials is the best scientific way to get information or real data on real outcomes, but you have to control all the factors. So what they did in the 1970s is they sent out invitations to screen, and this number here is the number of women. So these were very large trials. This trial at the bottom here had over 200,000 women, and they had a lot of women in all these trials. And what they found is at least a 25% reduction in mortality. And this was in the 1970s, and this trial cannot be repeated now because once they have found a reduction, they can't now uninvite women or not invite women when they know that the mortality rate is decreased. How this was also done was it was an invitation to screen. For the women, some women chose not to take the invite, but if out of the women who did, that were actually screened, it was more in the range of 38, close to 50% reduction in mortality for the women that actually showed up for the screening. So we'll go back in time and look at how things have changed. And here on the screen on the left is what a hard disk looked like in the late 1950s. And here in the present, there's the same amount, actually much more, 52,000 times more storage on this little thumb drive than there was in something that had to be lifted to get onto an airplane. So likewise, technology changes. In 1969, This is what a mammogram looks like, and it looks, unsharp, foggy. We get better in 1970s. And really, this is when the trials were performed. But today, this is a very crisp image of a mammogram. And I'm going to go over some techniques that have also gotten so much better. And they had a 50% reduction, close to that. And that was in the 1970s, and we have much better equipment and images now. So to look at this another way, what has changed since 1990 is that we've had a reduction in breast cancer mortality, approximately 37%. Now, cancer in general is in an upward trend, and breast cancer is in an upward trend. So if you compare that to males, the only difference here is females are screened, males are not. And breast cancer mortality has increased for males, which likely reflects that in general, breast cancer is in an upward trend. And we're saving more women than probably this 37%. We're probably in closer to 50, which goes along with also what they found in the randomized controlled trials. So what hasn't changed is that the mammogram is still a breast X-ray, and it still involves compressing the breast and using X-rays to take a picture. One of the issues with mammography and screening is that there is a limitation masking due to really breast tissue, fibroglandular tissue, or dense breast tissue, so that structures can overlap. And part of that is that the mammogram is really a flat picture, or 2D, and the breast is in reality is a 3D structure. So it's a bit like the horses in the snow. You can't see the depth in that 2D picture that there is really 5 horses in this picture when everything is sort of masked or camouflaged with the same background. Now, in the same way, and I think you've seen this slide before with Dr. O'Hara, but we have more of a fatty breast. This is the pectoralis muscle here, fatty tissue. Little bit of the white tissue is the glandular tissue we increase. And this is a fairly dense breast, and we get to the far right side of the screen, and you can see how this is more of the horses in the snow, how you could really miss cancer is white, breast tissue is white. So the more you get into this denser tissue, the less sensitive the mammogram becomes. It's really, really quite sensitive in the fatty breast, loses in the dense breast tissue. So what has come along is this 3D mammogram, or the digital breast tomosynthesis, and it's still based in X-ray. This is where the technologist stands to take the images, and this is the compression plate. But with digital breast tomosynthesis, there is a movement of the X-ray beam in a part of a semicircle, so that you're getting multiple, taking little micro images all around the breast, a slice at a time. So if this is a depiction of the blue balls would be representing what dense breast tissue could do, and this star, and this is actually what a cancer does look like, or can look like. There's a couple ways cancer can present, but the main thing that we're looking for as radiologists is this kind of spiculated starfish kind of looking. This is what a breast cancer, it's kind of a cartoon version, but that's what it looks like to us. And you can see when you make that a 2D image that the dense breast tissue can almost completely obliterate your ability to be able to see the breast cancer. Now, if you take these little images, they and pull out the slices, which is what the tomosynthesis is doing, taking, station per station, you can pull out the dense breast tissue and separate it from the cancer. So what this looks like in real life to us, not a cartoon version, this is a real person with dense breast tissue. Here's the pectoralis muscle. The circle is sort of the starfish or the cancer that's on the image. And when we run this real time, you can see how it's more like looking at a movie now. As a breast imaging radiologist, we look at a cine clip or view, and we have the ability to stop it at any point when we think we're beginning to see a cancer on the screen. So we go back and forth through that breast, and it does take a lot longer time to read these, because we're not just looking at a flat image anymore. We're actually looking for each projection of each breast, a movie, and looking to find the cancer as it is being kind of unraveled from that dense breast tissue. Now, these are just images pulling out the cancer so that you can see, if we pause our screen on the cancer, what that looks like. So pay attention to this part of the breast. And this is a blown up version of that, with that piece of that one screen, one slice of tissue taken out, and you can see the star or the cancer that is buried or hidden in that dense tissue. Same for this breast, a different woman with a breast cancer, and pulling that slice out. This is the 2D image. This is the 3D slice pulled out, invisible on this image, well seen. Same for all this dense breast tissue. When we only had 2D, you could see how we couldn't really find the cancer. So we have increased our sensitivity, again, pulling out the slice where the breast cancer is not seen. Even fairly big-sized cancers in the breast could be obscured with dense breast tissue, and you pull out and you see the kind of star appearance and cancer hidden in the breast on the 2D image. So what's really exciting is it's really rare in medicine that you have improvements in both sensitivity and specificity, meaning we increase our cancer detection rate, and we also decrease our false positives, or those recalls where a woman gets a phone call and has to come back. So rarely is it a win-win. Usually you're sacrificing one for the other. And we have done research here, Dr. O'Hara and myself, when she was chief resident with me. We looked at 77,000 mammograms, and we did a combination of the full field digital mammogram, or the 2D image, and then we compared that to the 3D images. And we studied this newer technique where the computer synthesized the 2D mammogram so that you could actually decrease the radiation, not having to take the 2D part, but get that information all from the reconstruction from the computer. And this is a chart from our research that was published in the Journal of Radiology. And this is short for 2D. That's the full field digital mammogram. We used to have to take both to get the cine view, or the moving part, the movie, and also the 2D. But with synthesizing them together, we can just take the one dose, which is the cine, and make the mammogram. And we found our our recall rates getting lower, which is what you want to see. You don't want to get a recall. We had less false positives. And what's more is we found more of the invasive cancers when we use this technique. This started in about 2012. We reviewed mammograms through about 2018 and then published it in the Journal of Radiology. So moving on now to another form of breast imaging. So mammography really shows regressive changes. It's the cancer reacting with the adjacent breast tissue. And you can see things like calcium deposits or this star appearance. And it's really the fibrosis that's happening in the breast, and that's why you're able to see it. Now, a more dynamic technique is something vascular-based imaging. That means you have to inject a contrast agent into the vein, just to start an IV, and you inject a contrast agent, and that's vascular-based imaging. And what we use is breast MRI. And why this works is because a tumor begins to grow and very early starts to recruit vessels that are next to it. And that's how it grows. That's how it gets its nutrients. It's taking up blood vessels that are sharing nutrients, and that's how it grows. Now, this is called tumor angiogenesis. And really what it is these leaky vessels that are you have contrast in the vessel, and it leaks out into the tumor, and then the tumor enhances. It is not the difference. One of the big differences for MRI and breast cancer screening is it's not limited by that breast density. It's that breast density that really gets in our way from seeing some cancers. And it's the most sensitive test for breast cancers that we have presently. It has a positive predictive value similar to mammography, which means when you do biopsies, what's your percentage of cancers versus false positives. It doesn't use X-ray, so it's no ionizing radiation, and it tends to detect the cancers that are more aggressive or higher grade, because it's tapping into that vascular enhancement that tumors have. So this is a normal benign breast MRI. So vascular-based imaging, this is the breast MRI. This is the same woman, extremely dense breast tissue. It's a whiteout, very difficult to see anything on this mammogram. Right breast, left breast, and this is right breast, left breast. What you can see is the all the vessels light up with the contrast agent, as does the heart. And there is no evidence of tumor. That's just a normal background with nothing enhancing. So to look at this a little closer, this is how we manage these images. We place the woman in the MRI machine. There's a magnetic background using radio waves, and we get images from that. This is the unenhanced. We inject the contrast. You can see enhancement in the vessels that come off the heart, and you can see what a cancer does. It takes up the contrast, and then subtract that image out so that all you're left with is what is enhancing, and that gives us a very easy to see bright image of a cancer and its size, and we can see it through the background dense tissue. This is a compilation image of all the slices. These are separate slices in the breast, and this is a compilation of all the slices put together so that we can see in one image the entire breast. This is without cancer. This has a fair-sized cancer in this breast. So, vascular-based imaging. This is the corresponding mammogram. Dense breast tissue in this area, very difficult to see. Image on the right is the breast MRI. You can see the heart, the vessels coming off the heart, just some little background enhancement, but like a light bulb, taking up that contrast due to the leaky vessels and the cancer tapping into the blood vessels. This enhances and very clearly shows us a cancer that would be difficult to see on the mammogram. Likewise, this is a woman who came in. This is her right breast, left breast. We can see, because it's mostly fatty tissue in this back part of the breast, no problem seeing this cancer, but very difficult to see this cancer in the right breast. Same woman placed in MRI scanner, enhancement in the heart, vessels enhance. The cancer that we see in the back part of the breast on the mammogram, but difficult to see, but also lighting up like a light bulb on this breast MRI, is the cancer that's hidden by the dense breast tissue. So in 2007, the American Cancer Society guidelines for using breast MRI as a screening modality was fairly limited only to the very high risk women who have mutations in their genes or a syndrome that predisposes them to get breast cancer. But they didn't make comment on women who have less than a genetic risk, but still are at a higher risk. Prior biopsies that showed atypical cells, women who have heterogeneous or extremely dense breast tissue, there was really insufficient evidence to recommend for MRI screening. And this is kind of the normal risk, and there was recommended against breast MRI screening at that time in 2007. And I like to intermingle with case examples so that it becomes a more real lecture of what we actually do every day. So a woman, 45 years old, has a prior history of left breast carcinoma for which she had a mastectomy. She is a high risk or BRCA gene, BRCA2 mutation carrier, and she presents for high risk screening breast MRI. This is her baseline MRI. This is a reconstructed left breast. Initially, when you are immediate post-op, we can see healing tissue, and that recruits contrast in vessels. So that is normal post-operative change in this reconstructed left breast. And here we don't see it the following year. But in the right breast, this is perfectly normal. And this is normal negative breast MRI, no evidence of cancer. 1 year later, there is a new enhancement or mass in the right breast that proved to be cancer after biopsy. So this is literature from Christiana Cole. She's the probably the lead researcher and has been doing research for years in breast MRI screening. And the take home from this slide is that the cancer detection rate, this is per 1,000 women, and MX in this slide stands for mammography, and what you're going to see. So approximately 5 out of 1,000 screening mammograms will show signs of cancer. If you put ultrasound with that, you have mammogram and ultrasound, you can find approximately 2 more cancers per 1,000 women. If you have MRI, your cancer detection rate is almost doubled. And the very few cancers are not seen with MRI. They're the precancers or the ductal carcinoma in situ, the stage 0 cancers. So that's why still a need for mammography for the precancers. But the take-home message from this slide is that if you have a mammogram and a breast MRI, you find all the cancers, and ultrasound did not contribute to finding more cancers if you use breast MRI and mammography together. So another case example, a 58-year-old female presents for a routine screening mammogram. She has a family history of breast cancer in her mother, her sister, and her grandmother. And Dr. O'Hara talked to you about the Tyrer-Cuzick risk score. And in this case, because of multiple factors that she answered on the questionnaire, it came up that her risk is at 29.4%. This is her mammogram, and you can see the pectoralis muscle here, and she has dense breast tissue behind the nipple, but negative, otherwise no evidence of cancer, and otherwise scattered tissue. Her breast MRI shows an enhancing mass, small in size, about or just less than a centimeter. These proved to be benign negative lymph nodes when they were viewed on the source images, but this is that compilation image, and this was the only thing that presented as a suspicious mass. Now, how do we biopsy these if you don't see them on the mammogram? Well, we have MRI guided biopsy, and it uses the same equipment that we would use for biopsy if we were biopsying under mammogram or ultrasound. But in this case, the computer tells us exactly where to go in the breast. It tells us how many boxes over, down, or up or down, and the depth. And the radiologist will then place the needle into the exact position, will guide the needle into the level that the computer, when we mark it, the computer gives us X, Y, and Z coordinates, and we can get to the exact position of the mass and sample it or biopsy it. And in this case, this was a differentiated invasive ductal carcinoma that was ER positive, PR a little bit positive. And I do believe that Dr. O'Hara had some explanation for what those markers mean. But this is kind of, if you will, a garden variety invasive ductal carcinoma that was found on the breast MRI only. So the reason we don't, or we haven't in the past used breast MRI to screen all except the very high-risk women is the cost of the MRI. The MRI is an expensive study by definition. Screening studies have to be relatively low cost to be able to get them to everyone in the population. The time cost of MRI in the past was anywhere between 35, sometimes 45 minutes to pull out all that information after the injection of the contrast and to perform a breast MRI. And there really, lack of availability, there really aren't enough breast MRI scanners in the country, the world, to scan every woman. So, and it had a perceived lower positive predictive value, but in literature that proves to actually be equal to mammography and acceptable. So what we can do is do a fast MRI that would answer if we can make the MRI less in cost, less in time, therefore more available. And the literature that Christiana Kuhl, again, the pioneer really of using breast MRI for the average risk woman, took 3,800 screening breast MRI exams. And this is very consistent across the board, found, this 15.5 per thousand. And this is very important. The interval cancer rate was 0. That interval cancer is a cancer that pops up in between your two screening tests. So for mammography, you get yearly mammograms, and it would be one where it was felt maybe a palpable lump, and that popped up before the yearly interval. We find the interval cancer rate when a woman has an MRI is 0. And MRI detected cancers when they were small, node negative, and the clinically relevant ones, not so much those stage 0, but the ones that really, save lives, the ones that have started to invade into the vessels. So here's another example. A 50-year-old presents for routine screening mammogram. She has extremely dense breast tissue. She has some family history in a mother who was postmenopausal, and she requested to her referring physician that she wanted a screening breast MRI. Here is her mammogram: right breast, left breast, white, very dense breast tissue. Here's the left breast, and I positioned the breast MRI the same positioning that we do for the left mammogram. So here's the pectoralis muscle, the front part of the breast, nipple, dense breast tissue in between, and there's no evidence of cancer on this mammogram. On the breast MRI, we see 3 adjacent enhancing masses that were all of similar but all invasive carcinomas at an early stage. These were all taken out with lumpectomy. This was, I know this woman, and she's doing fine today. So what is fast MRI? How can we get this MRI out to the public in a more efficient way, less expensive way? How is it different than the long version of MRI, and is it as good? So fast MRI, when you place a woman or a breast or a body part in an MRI scanner, magnetic resonance imaging scanner, there are different weighted, we call them sequences, and you can plug all this into the MRI scanner, and we do, these are just names for different weightings that we use. And we use an early contrast run, and then we wait a little bit, and we do, after things settle down a little, we do more imaging post-contrast, 1 minute after, and then a couple minutes after that, a third run of the contrast. Well, what the fast MRI is what is the very least that we can do and still get the same information with that MRI? Can we decrease the amount of time in that scanner, the amount of sequences, and make this accurate the way the longer protocol is? And for many years, we were all doing this protocol. So it's been ignored, again, cost, time, lack of availability. But if we can get all of those down, the cost and the time, then we can increase the availability. And we now have this down to about a 5 to 7 minute scan. And the concept is we want to make a breast MRI a real screening tool that can actually be used, and with low cost, if we can do it quick, less time, less than 10 minutes, and have a similar positive predictive value compared to mammography. So it really rivals that in its ability. And we see with the MRI, 150% increase in cancer detection rate. It's remarkable. So then there was literature to support that this abbreviated, we can't just go out and assume that we're going to, these things have to go under controlled research protocols. And again, Christiane Kuhl, she's in Germany doing this research, and she found that MRI is very sensitive, and the abbreviated MRI had a very good sensitivity, 100%. And again, yield a cancer detection of approximately 18 out of 1,000 when compared to mammography, which is anywhere between 5 to 7 or 8 per 1,000. And not just her research over the years, but others have compared the FAST or the abbreviated MRI to the full research protocol, and it is really very similar. So now here in Delaware, this was the ECOG-Akron study, was a randomized controlled trial that we took part of in Delaware. And it was major institutions and cancer centers across the United States. And we put this protocol, we looked at a comparison of this abbreviated MRI and compared it to the digital breast tomosynthesis for average risk women. None of them were high risk. Their only difference was that they had dense breast tissue. And because we had read so many here in Delaware and participated in this Akron trial, we were part of this JAMA research paper. And what this Journal of American Medical Association article showed is that when you compared the abbreviated MRI, it compared the abbreviated MRI to the digital breast tomosynthesis in dense breast women. It recruited 1,400 women who underwent both. The randomization was whether they got the MRI first versus the digital breast tomosynthesis, because there could be a thought that if you knew if one was positive. They were actually read, we read a lot of these here in Delaware, and they were read by different readers and also randomized. Getting the mammogram first versus the MRI first was a completely random, and they were not read, the same woman was not read by the same reader, so that we could keep that, we wouldn't be biased by the other study. And what this showed was that the abbreviated breast MRI showed significantly more cancers. Now realize this is in the average, it's 11.8 per 1,000, but that's in the low risk. There's no high risk or family history or anything that would make this woman high risk. It's just the average risk. Likewise, with the digital breast tomosynthesis, 4.8 per 1,000 women were found to have cancer. This is the cancer detection rate of MRI in the average woman, and X-ray or digital breast tomosynthesis in screening average woman with no increased risk per 1,000. And again, this was our study in the Journal of AMA. And there was no, this is important, that there were no invasive cancers missed. If you did the MRI, obviously if you did the mammogram, there's more in the MRI, but there weren't there were no cancers, invasive cancers identified on the digital breast tomosynthesis that the MRI did not see. So the biggest take home from that research, and again, proud to be part of that here in Delaware, is that among women with dense breast tissue undergoing screening, abbreviated MRI was associated with a significantly higher rate of detection of the invasive cancer compared to that of the digital breast tomosynthesis alone or the mammogram alone. So I would like to conclude there, and I would like to thank the Delaware Breast Cancer Coalition for allowing me to speak to you today, and also thank them for everything that they do for the women in Delaware. Thank you for listening.